Hello students, in today's session we'll be discussing about acute intestinal obstruction. Generally a surgery topic where the acute intestinal obstruction is predominantly due to an obstruction, either an intraluminal or extraluminal obstruction of the intestine. But there are certain medical conditions that can manifest with this. So in today's session we'll be discussing about the intestinal obstruction, the pathophysiology, the complications and the medical management of intestinal obstruction. Now the most common causes of intestinal obstructions are probably related directly to the intestine. So they can be extrinsic diseases like adhesions, post-surgical adhesions that could happen, or an external hernia, or a tumor which is compressing from the outside, usually the ovarian tumors, or an endometriosis, sometimes due to a intraperitoneal abscess, sometimes due to fibrosis like the retroperitoneal fibrosis or sclerosis that can happen. It could be intrinsic intestinal problems like congenital, like the malrotation, atresia, stenosis or the congenital bands. It could be inflammatory conditions like IBD, Crohn's, diverticulitis, tuberculosis and radiation. It could be malignancies of the intestine, sometimes traumatic. It could produce hematoma or strictures, and some other causes like an intussusception or a volvulus, or sometimes with the Hertzsprung disease that could happen. Next, you could have intraluminal problems, that is directly problems within the intestine, not in the mucosa. It is not in the wall, it is intestine, like could be the Bejo's feces, foreign bodies or gallstones or enteroliths that could happen. These are the common conditions that can produce acute intestinal obstruction. Out of these, the majority of the causes are due to adhesions, sometimes due to hernia, malignancies and inflammatory bowel disease. Now, if you look at the entire spectrum of the intestinal obstructions, we classified as based on how severe is the obstruction. We can classify it as partial obstruction or a high grade obstruction or a complete obstruction. In other ways, you can say it's a simple obstruction or a strangulated obstruction, especially in hernias. We say it's a simple hernia when it is reducible, strangulated when it is irreducible, and then there is a chance of ischemia that's happening. The obstruction can be mechanical, as we said in most of these diseases, or it could be functional. That's very important. So functional obstruction, otherwise called as the paralytic ileus, could be caused due to multiple metabolic causes, important being hypokalemia, hypomagnesemia. It could be due to acute pancreatitis or an acute inflammation in the abdomen. Drugs can produce ileus. So these are the important causes of functional obstruction that could happen. Most important cause world over is post-operative adhesions that you would see. Let's discuss some of the causes and what could be the pathophysiology in them. So one of the important causes which can manifest is the volvulus. So volvulus is where the bowel twists along its mesentery, either completely or incompletely, and that can cause both mechanical obstruction as well as the vascular compromise can happen. So more than 70% of the volvulus usually affects the large intestine. So large intestine is the most common part that is available, and the cecum and the terminal ileum are the most important part of the large intestine which turns onto that, and that can manifest with variety of symptoms of intestinal obstruction. As I said, functional obstruction or a pseudo obstruction is one thing that we have to always remember of. Now this is what we call it as the ileus. So paralytic ileus, as we said, there are a lot of medical causes for this, and the important one that we should always remember is the hypokalemia, hypomagnesemia and acute pancreatitis. Also the patients can have severe uremia or an acidosis or sometimes hyperglycemia. It could be secondary to drugs. Large number of drugs cause ileus like opiates, antihistamines, anticholinergic agents. Intestinal ischemia can produce that. Also severe sepsis, intraoperative radiation exposure. Now, or you also have a condition called as an Achith syndrome. Now, Achith syndrome is nothing but an acute pseudo obstruction of the colon, and it is basically secondary to the colonic dysmotility that could happen. Sometimes connective tissue disorders like lupus or scleroderma can manifest with intestinal obstruction as a manifestation that you would see there. Now, when we look at the pathophysiology of an obstruction, now as the part of the bowel gets obstructed at a particular part, there is a proximal dilatation that happens, and because of that there is increased peristalsis that is happening to make sure the bowel starts moving. So there is a dilatation that can happen, whatever contents keep on increasing that, and there is an increase in the intraluminal pressure, and sometimes it can lead to perforation especially. Initially at that part you could have a venous congestion that could happen, lymphatic obstruction that can happen, and significantly the ischemia can worsen to the arterial and there could be necrosis that could be seen there. And as the stasis happens, the organisms also increase, so the bowel organisms increase and they can get percolated into the systemic circulation, resulting in septicemia that you could get. Now, inflammatory edema, whichever is happening, will release a lot of reactive oxygen species, activates neutrophils, macrophages, and they would accumulate there. Also, there is a lot of vomiting that could happen, or the patient cannot be able to take food, and that results in significant amount of dehydration that could happen. So, anorexia, very important feature, nausea and vomiting. So, with the significant vomiting, what will ensue is a loss of H+. So, there will be a loss of H+, there will be a loss of potassium, that's very important, and a lot of chloride that's lost with the free water loss. So, the patient will have metabolic alkalosis, especially hypokalemic metabolic alkalosis, and they can have something called as a paradoxical aciduria. That would be one characteristic feature that could happen. Now, sometimes you could have something called as a closed loop obstruction. Now, what do you mean by this closed loop obstruction is when the distal and the proximal part of the bowel segment gets obstructed, like in a volvulus. So, there is a segment of the bowel which is entangled between the two obstruction segments, and there is strangulation of that, and the risk of vascular compromise is much higher, the inflammation is much higher, and there is a high chance of sepsis and perforation that could happen. Now, what would be the clinical features when a patient comes with that? The cardinal signs would be a colicky abdominal pain. That's the most important part of that. And as the obstruction increases, there will be abdominal distension. The patient will complain of emesis and obstipation. That's very important. It's not only constipation. Obstipation is an important feature that you would get. That means the patient would not be able to pass the feces, nor even the flatus that could happen. More intraluminal fluid gets accumulated, more the distension would happen, and more the patient would have emesis and the complications of that. And as the emesis would increase, possibly the chances of complications related to the dehydration, electrolyte disturbances would also be there. Again, we'll have to take a history of abdominal surgeries in the past, because that's the most common cause, adhesions. Also history of any cancer, any warning signs that we'll have to take, any pancreatitis, alcohol consumption, etc. we'll have to take history very importantly. On examinations, these patients will have tachycardia. They may have a little hypotension based on how severe the dehydration is. Fever is a very worrisome sign, because that would indicate that there is a transmigration of the organisms and infection has set in. And when you examine, the abdomen will be painful, there is tenderness that you would find, and you might find a gaseous distension, you might get tympanic note that you could find there, and on auscultation you get the classical tinking, high tinking bowel sounds, musical bowel sounds, what we call it as the borborygmi. That is the important feature that you would get it. Now, in adynamic ileus, you would get absent bowel sounds that you would see there. So, initially there is a increased bowel sounds, and later it becomes hypoactive, and you would find certain surgical scars, etc. on the abdomen, which would always say that these patients could have prior surgery. That's it. Always examine for hernias. So, hernias are evident externally. So, the femoral hernia, the inguinal hernia, and the other hernias, look whether they are reducible, is there any tenderness there. That is an important feature which you can always find out. And once the peritonitis has set in, the patients can have guarding, rigidity, etc. that could be seen. Now, if you have a colonic volvulus, you will have an asymmetric distension of the abdomen with the vomiting and obstipation, and you would get the classical bowel sounds which are increased. Now, when you suspect an obstruction, the first and most important investigation that we are supposed to do is an erect abdomen X-ray, but simultaneously do the blood investigations, get the complete blood count, see the total count, differential count, get the electrolytes and RFT to see for any abnormalities. The electrolyte abnormalities, we will have to correct it. The BUN can be increased. There could be hyponatremia, there could be hypernatremia also. Also, get a very important investigation that you always should not forget is the amylase and lipase. These patients, a per rectal examination would help you. Sometimes it might show you the bleed or it might show a block that could be seen there. If the total count is elevated and the neutrophilia is there, it's not always suggestive of an infection. It could be a part of an inflammatory process that's happening, ischemia that's happening, but that is an important feature that you should always think of. And you would do the liver function test, and the CPK etc. may be needed. The next most important investigation that we have to do is a plain X-ray of the abdomen. Now, the plain X-ray of the abdomen will classically show us the obstruction. So, you will find multiple air fluid levels. So, normally we do find only two air fluid levels. One is at the stomach, that is the fundus, one is the duodenum. These are the two which you could find. Anything more than two would be suggestive of obstruction that you could see. So, you might find the pattern which could be seen at various parts. So, you might find a staircase pattern in the center. That would mean small intestine would be obstructed distally, that's there. So, that would be in the center, whereas the colonic you would find the shadow in the periphery with the hostrations that you could see there. So, you would find a bowel loop, any bowel loop which is more than 2.5 centimeter in dilated along with air fluid level would suggest a obstruction that you could see there. Again, in the colonic volvulus, you would get the classical inverted coffee bean appearance of the bowel that you could see there, and that is pretty diagnostic of volvulus that you would see there. You can get an ultrasound abdomen, but that may not be so much. CT scan is very specific, almost 95% specific to look for the obstruction you would be able to make out in that. So, here you could see there, if you see the seat of the films, you will find a multiple air fluid levels, and you do find that there is a partial small bowel obstruction in the section B that you are seeing there. You would classically see that there is a partial obstruction, and on decompression it has cleared, that you see there. Now, CT would always help you to identify the site of obstruction, and you can give some oral water soluble contrast, and you might be able to see the classical obstructive like a bird beak appearance or a C loop or a whirl that you could see, you would find it. As I told you, ultrasound is not a very important investigation. Earlier barium studies were done, but now we do not use barium because obstruction would preclude the use of barium that is there. So, how do you manage these patients? So, acute intestinal obstruction is an emergency. So, first and more important, stabilize the patient, check the airway, breathing, circulation, start IV fluids, make sure the sugars, electrolytes are monitored and maintained. Nasogastric aspiration to decompress the intestine is a very important thing that would prevent the further distension of that. Always monitor the urine output. You might require to catheterize the patient. Based on that, you would require to give the fluids, and any patient who has a complete obstruction would require emergent surgical intervention to look for the obstruction that is there, what is the site, and relieve the obstruction. Also, if there is strangulation or there is a gangrene that's happening, we require to resect that part of the bowel. Now, ileus is a very common problem, either medically or post-operatively you'd find. You give them IV fluids, nasogastric aspiration. You can use certain prokinetic drugs, but not yet, they are not very strongly proven there. You have certain newer drugs that are there, that is the mu opioid receptor antagonist. The two important drugs which have come are the alvemopan and the methyl naltrexone. They can post-operatively be used to decrease the ileus that could be seen. Colonic pseudo-obstruction, that is the Ogilvie syndrome. Now here the drug that has been tried is the neostigmine. So neostigmine has been tried, which is a acetylcholinesterase inhibitor that is considered to be stimulating the colonic motility. Very important, whenever we give this neostigmine, monitor the heart rate. Sometimes you might require atropine to be given also. Sometimes if these patients do not respond to these therapy, sympathetic blockade has been also tried. The volvulus, patients with sigmoid volvulus, you can decompress by putting a, proctoscopically you can put a tube there. So you can put per rectally a tube or a flexible proctoscope or a sigmoidoscope and insert the tube and decompress it. Successful decompression would relieve the symptom. Cecal volvulus, you cannot do that. You will have to do a laparotomy and decompress it. Very, very importantly, intraoperatively, you should make sure that the bowel that has been in this segment, wherever there is an obstruction or a volvulus, the viability has to be assessed. Because if you do not do that and just relieve the obstruction and come back, the viable bowel, if it is possibly in ischemia, can result in perforation later. So you should assess the viability, and if you find that the bowel is not so viable, it requires resection. Mandatorily it requires resection. Some of the specific types of obstruction, you could have an intersusception, which is more common in children, and again that requires a manual reduction, that is open reduction is needed, and sometimes resection and colostomy might be needed. Also gallstone ileus, this is an important feature where there is a fistula that is formed between the cholecystoduodenal fistula and so the gallstone would go down and block distally. In such a case, definitely you would require to do a cholecystectomy, make sure the fistula is healed there. This requires an emergent surgery, that is very important. Post-operative is by far the most common clinical scenario where we get bowel obstruction. So early we would see it within possibly the first week of there, where it could be mechanical obstruction, which could be due to a hematoma or maybe vascular ischemia that's happening. Subsequently, the obstruction is secondary to adhesions that would form. So please remember, the most common cause for intestinal obstruction in adults is adhesions. Students, in today's session, we discussed about acute intestinal obstruction.